Clinical chemistry, metabolic syndrome. Metabolic syndrome is a series of risk factors that predisposes a patient to developing heart attack, stroke, or even type 2 diabetes. So the deadly quartet is listed here: insulin resistance, dyslipidemia, hypertension, and central abdominal obesity. Insulin resistance is when the body becomes less responsive to insulin, requiring that the pancreas produce more and more insulin in order to have the same effect. So think about it as maybe one molecule of insulin was needed in order for the cells to be able to respond to glucose and take up glucose and utilize that glucose. And now, instead of just one, it needs maybe 3 or 4 or 5 or 6. So it's causing the pancreas to have to produce more and more insulin in order to keep up with the needs of the body. Dyslipidemia is talking about dysregulated lipids. So typically, we're talking about high triglycerides, high LDL, low HDL. Hypertension is talking about high blood pressure. High blood pressure is typically caused by the narrowing of the inside lumen of the blood vessels. So if you think about a water hose, for example, if we have an open end of the water hose, water is going to just pour out of the end of the hose. But if you decrease the volume, so if you put your thumb over the end of that hose, you're increasing the pressure in that area because volume and pressure are inversely related. So as you decrease volume, you increase pressure, and the water is going to spurt out at a much faster rate. And that's because it's now been pressurized due to your thumb being over the end of the water hose. So when we have fatty streaks or plaques that accumulate on the inside of the blood vessels, that can lead to a narrowing of the inside of those blood vessels, and that can increase the blood pressure in those blood vessels. So that's what we have hypertension. And central or abdominal obesity is talking about visceral fat. So we're talking about fat that's specifically deposited in the abdominal region. There's some subcategories of metabolic syndrome that are listed here, so you can take a look at those. And then this is just kind of a flow chart showing how everything's interconnected. So obesity is related to a high BMI, body mass index, and waist to hip ratio. Insulin resistance is related to fasting insulin and fasting glucose. Lipids, HDL cholesterol would decrease, triglycerides would increase. Blood pressure, we're talking about systolic and diastolic, both would be increased for increased blood pressure. There are 2 organizations that produced diagnostic criteria for metabolic syndrome. You can look at both of these. When you're asked questions on the exam, they will be generalized questions, but take a look at both of these and review the diagnostic criteria. This is a table that shows common causes or modulators of risk factors of the metabolic syndrome. So hypertension, here are some of the common causes: overweight or obesity, common causes; insulin resistance, elevated triglycerides, and low HDL. So you can take a look at this. You can see that obesity is a cause for almost everything. So good diet and exercise is always essential. Cigarette smoking is another common factor that you're going to see across multiple categories. You can go ahead and pause the video and take a look at this table a little bit more in detail. There is an interrelation between atherosclerosis and insulin resistance. So atherosclerosis is when we have plaques accumulating inside of the blood vessels that increase blood pressure. Insulin resistance and atherosclerosis are all related to hypertension, obesity, hyperinsulinemia, so that's producing too much insulin, diabetes, hypertriglyceridemia, too many triglycerides, small dense LDL. Small dense LDL are a subcategory of LDL that have a higher propensity for depositing fatty streaks in the blood vessels. Low HDL, so your HDL levels are decreased, and coagulability, so increased likelihood of the development of clots or blood clotting. So the role of obesity, so visceral or abdominal fat versus subcutaneous fat. Subcutaneous fat is generalized, it's found all over the body. Visceral fat that specifically accumulates in the abdomen, that's a little bit more dangerous and a little bit more indicative of metabolic syndrome. Subcutaneous fat is cushy, it's underneath the surface of the skin and it kind of looks lumpy from the surface of the body, while visceral fat usually makes the abdomen look solid, just distended. Insulin and leptin. So insulin and leptin both act to suppress the appetite. Leptin is secreted by adipose tissue and it tells us not to eat. So signals the hypothalamus when enough energy is stored. Proper function leads to the production of subcutaneous fat, but with insulin resistance, glucose is then stored as visceral fat. So if we have leptin and insulin are functioning properly, then we have our normal subcutaneous fat that is produced. But if we have insulin resistance, glucose is going to be stored specifically as visceral fat. Other factors that increase visceral fat include chronic stress, cigarette smoking, and genetic predisposition. The contribution of visceral fat to metabolic syndrome. So free fatty acids released from visceral stores are transported to the liver. They're metabolized to LDL. So visceral fat is linked to an increase in LDL and a decrease in HDL, and this promotes insulin resistance. Angiotensin is an important regulator of the sodium balance. Increased levels lead to vessel constriction, and also C-reactive protein and IL-6 levels are elevated. Dyslipidemia is referring to elevated total triglycerides, reduced HDL, and increase in small dense LDL. So here we can see a list of what's increased and decreased. So increased would be triglycerides, VLDL, LDL, and small dense LDL, and ApoB. What's decreased is HDL and ApoA1. Small dense LDL and CHD. So increased vascular permeability, so the blood vessels become more permeable. Increased susceptibility to oxidation, a conformational change in ApoB, which causes an increased circulatory lifespan, decreased affinity for LDL receptor, and this is association with insulin resistance syndrome and association with high triglycerides and low HDL. Hypertriglyceridemia and CHD risk. An accumulation of chylomicron remnants, accumulation of VLDL remnants, the generation of small dense LDL-C, an association with low HDL-C, and increased coagulability. Increased coagulability is due to increased plasminogen activator inhibitor, increased factor 7C, and activation of prothrombin to thrombin. All of those factors would increase the coagulability of the blood. Insulin resistance and hypertension. So in this, we have an increased catecholamine release, so epinephrine, norepinephrine, and dopamine. Increased activity of the sympathetic nervous system, which leads to increased blood pressure and heart rate. If you think about the function of epinephrine and norepinephrine, that's the fight or flight response. So in the fight or flight response, we're going to have a higher blood pressure to get more blood to the areas that need to fight or run away, and we're going to have an increased heart rate. Loss of signaling mechanisms controlling vasodilation and anti-inflammatory effects of insulin. Effects on sodium balance and water retention, the volume expansion and increased blood pressure. Factors promoting thromboembolic disease. So thromboembolic disease, a thrombus is a clot that's in a blood vessel. An embolus is a moving clot, so that's when that clot dislodges from a stationary position and starts to migrate through the blood vessels. When it becomes an embolism, and it's actually migrating through tissues, that's when you have the risk of it getting lodged in the lung, causing a pulmonary embolism, or getting lodged in the brain, causing a stroke. Increased plasma fibrinogen, increased plasminogen activator inhibitor 1, and increased platelet aggregability all cause thromboembolic disease. The diagnosis for metabolic syndrome is based on physical exam and patient history, so obesity or BMI, hypertension, age, ethnicity, menopausal status, smoking, low socioeconomic status, high carbohydrate diet, and ethanol abstinence. A lipid panel, the lipid triad, so increased triglycerides, increased small dense LDL, and a decreased HDL would be indicative of metabolic syndrome. Glucose tolerance versus insulin intolerance. So the majority of patients have normal fasting glucose levels, but the insulin and C-peptide levels are increased. So they need more insulin to maintain the homeostatic regulation of the glucose in the body. But at this stage, they're still able to regulate their glucose. So they haven't actually developed diabetes yet. They're just pumping out excessive amounts of insulin because they have insulin resistance and they need more insulin to do the normal job that they would have done previously. So glucose levels are typically normal, but we do have increase in insulin levels. Other markers are C-reactive protein, so that's a general inflammatory marker. Other inflammatory markers include ESR, the sedimentation rate, or erythrocyte sedimentation rate, fibrinogen, white blood cell count, cytokines, adhesion molecules, uric acid, GGT, fasting homocysteine, and risk factors for cardiovascular disease, utility, and metabolic syndrome is unclear. The treatment, diet, and exercise. The goal is to reduce weight, have a low sodium diet, have a low glycemic index, and ethanol consumption in moderation. Control of diabetes. So there's pharmacological interventions. Hypertension can be controlled with drugs, cholesterol, lipid levels. We use statins for prothrombic tendencies. We can use aspirin for.